Okay, so we talked about the BUN. Now let's look at the creatinine. And this will be the last video for renal function that we're going to be talking about. Our serum creatinine level. Creatinine is a byproduct of muscle metabolism. We should have a stable value, and it's usually very narrow. As you can see, normal here is I've seen 0.6, I've seen 0.5, and I've seen 0.7, but usually they don't want it any higher than 1.2. Should have a stable value. Levels of production are constant and proportional to muscle mass. Normally, it is not reabsorbed, it's cleared. When it rises and accumulates in the plasma, it represents a diminishing glomerular filtration rate. If it's doubled, the renal function is half of normal. If it's tripled, about 75% of renal function is lost. So you can see at 0.7 to 1.2, I've seen it at anywhere between 6 and 9 with people in chronic renal failure or on dialysis. So serum creatinine is not sensitive to early renal damage. Usually you're going to see the BUN go up faster. It responds slower than the blood, urea, and nitrogen to hemodialysis. Together with the BUN is used to differentiate if we're in pre-renal, intrarenal, or post-renal azotemia. So the BUN to creatinine ratio here you can see normal, and this is BUN's on the left and creatinine's on the right. 10 to 1. Dehydration would be 15-20 to 1. Pre-renal and post-renal would be greater than 10 to 1, and renal disease is greater than 10 to 1. And the creatinine will rise, like I said, proportionally. Creatinine clearance, what that means is the amount of the blood that is theoretically cleared of creatinine by the kidney in 1 minute of filtration. Normal is 90 to 130 cc's per minute. It provides a good measure of renal blood flow and GFR because serum levels are related to a 24-hour urine volume. Insulin, a substance with a stable plasma concentration, is used to assess the clearance. Characteristics of normal urine volume for most people is 1 to 2 liters in 24 hours, but it's going to vary considerably with age, how much you drink, how well is the host? Are there other diseases? How well is your kidney? And urine. Yellow to amber, but varies with concentration. And I am here to tell you, we need to have it clear. When I have clear urine, I'm very happy with myself because I know I'm drinking enough water. So if your urine is dark yellow, that is a clue for you to start drinking water, and a lot of water. Your body needs it. Our body components are more than, remember, 60% water. So if we've got thick yellow urine, that's not good. It's not good for our normal metabolic processes. Color is due to urochrome, which is a breakdown of bile, and urobilin, which is bilirubin reduction, and it's always yellow. That's why urine's yellow. Concentrated urine is darker in color, and I already said that. We don't want that. And it can be red from beets, and a lot of medications can discolor it orange, but we usually know that, so we can tell them that. Turbidity is transparent when fresh, and here we go, transparent, that's what we need. Odor is mildly aromatic, a little bit of ammonia. The pH ranges between 4.6 to 8, the average being 6, so it's basically more acidic. Varies with diet, protein, acidity, vegetarian, they're more alkaline. Specific gravity, what is that? It marks the density of our urine. It's the ratio of weight of a volume of substance to the weight of an equal volume of distilled water. And it's another very small margin. The range is 1.001 to 1.035. The higher the concentration of solutes, the higher the specific gravity. Abnormal constituents of urine. Albumin, glucose. Albumin needs to be in the plasma. It appears in small amounts because it is too large to pass through the capillary fenestrations. Presence indicates permeability of filtration membrane due to injury, disease, hypertension, bacteria, toxins, ether, heavy metals. It goes on and on. But we need the albumin not in the urine. We need it in the plasma. Glucose indicates diabetes mellitus, which is sugar diabetes, occasionally caused by stress, excessive epinephrine secreted, and we talked about that with stress, because then we end up with glucagon or cortisol, which are high sugars in the blood continually. Epinephrine stimulates the breakdown of glycogen and liberation of glucose from the liver. That's epinephrine, but we also know the adrenals will secrete cortisol. More abnormal constituents in the urine would be our red blood cells. Generally indicates a pathological condition. We should not see red blood cells in the urine. Acute inflammation of urinary organs or irritation from kidney stones, tumors, trauma, kidney disease, a possible contamination, which would be like from your menses, and that's normal. But ketone bodies shouldn't have any in the urine. Indicate diabetes, anorexia, starvation, or too little carbs in the diet. Bilirubin, when red blood cells are destroyed by macrophages, the globin portion of the hemoglobin is split off, and the heme is converted to biliverdin, which is converted to bilirubin, which gives bile its pigment. But it should not be. Bilirubin usually is excreted out through the stool, and it's really the one that's responsible for our stool being brown. Should not be in the urine. Urobilinogen, again, we've got our bilirubin breakdown from basically the globin portion of the hemoglobin molecule, and we've got urobilinogen will be the breakdown product of hemoglobin. Trace amounts are normal. Elevation may be due to hemolytic or pernicious anemia, infectious hepatitis, biliary obstruction, jaundice, cirrhosis, congestive heart failure, and mono. Casts are tiny masses of material that have hardened and assumed the shape of a lumen of the tubule in which they were formed. They're flushed from the tubule when filtrate builds up behind them. Named after the cells or substances that compose them or based on their appearance, because here it says, it's tiny masses of material that have hardened and assumed the shape of a lumen of the tube in which they were formed. So you can have red blood cell casts, white blood cell casts, epithelial cell casts, but we shouldn't be seeing those in the urine either. And then microbes. Number and type vary with specific infections, and we know Proteus is in here too, but most common, as I've said about 5 times in this whole PowerPoint, is E. coli. Okay, that's the end of our PowerPoint lecture and patho lecture on kidneys. There's a lot here, a lot. Please refer to your book. If you do not understand the differences in them, I think once you listen to it and take notes, you'll see the difference between acute pyelonephritis and acute glomerulonephritis, acute kidney injury to where we can recover versus chronic kidney to where it's going to lead to failure. So I will talk to you soon. Bring your questions to class next week, please.